can we talk about patient call bells? For those of you that have been on placement already, you will know exactly what I'm talking about. And for those of you that are yet to go into clinical practice on a placement, the patient call bell system is, as it says, it is a mechanism for patients to alert a healthcare professional in that surrounding area to come to their aid. However, what tends to happen is I, as a nurse, have my X amount of patients, and whenever one of their buzzers or patient call bell goes off, I will attend because I am their registered nurse. I am the nurse responsible for their care. What tends to happen in practice, another patient might be calling for assistance who may not be one of the patients on my list for the day, but I can still go to that patient if I'm available to find out what it is that they need or want. Now, if I have my list of patients and one of the buzzers that's calling isn't one of my patients, do I or do I not go to that patient? If somebody in your clinical area is needing assistance, of course anybody can go to that patient. There are, however, very specific times in which you probably wouldn't want to go into a patient's room, as my background is within immunology, BMT, oncology, hematology. There are some patients that you want to limit the amount of different people entering into their space. So I wouldn't just necessarily go into any patient, especially if they're a BMT, a blood or bone marrow transplant patient. There are other situations as well where you may want to be cautious about entering into a patient's room that you may not be the designated healthcare professional looking after them, and that might be something to do with religion or cultural elements that of course we as healthcare professionals always need to respect. So there are some times in which we might not want to just go and help everybody out by attending all of the patient call buzzers, but more often than not we should always try our best to attend to those calls for help. However, I do understand that as a student nurse, it can be really daunting, especially if you're just new into that environment and you've not yet managed to find out the types of clinical situations you're likely to come up against in that area. Or maybe you're a new learner in practice and you're just nervous. That's completely okay. We've all been there. However, it is something that we are going to want to try to overcome pretty quickly for many reasons, and I'll get to those throughout the video. And the idea behind this video is to really just demystify the room in situations where you will find yourself in, and I want to help you understand what that situation you're walking into might be, but more importantly, how you can react and deal with that situation firsthand. So, through my experience as a children's nurse, and I have to kind of give a shout out at this point to my friend called Jesse, who it was in a conversation with him at work where this topic came up, and he said, why don't you make a video on that? So I have, and if you're watching, thanks Jesse, kudos to you. As always, it's great to have these conversations because it does spark off different ideas of what, as a nurse working in clinical practice, we wish we could tell our younger selves as students. And as my role as an assessor, supervisor, and an educator within practice settings, I can use this channel to do exactly that. So through that conversation, we kind of narrowed it down to 4 key situations that you are likely to find yourself in when the patient call buzzer is going and you as a learner are going to want to attend to that bell. And the first situation is often for assistance. So that patient within that cubicle has pressed their call bell for some assistance. That could be things like getting out of bed, going to the toilet, eating or drinking, or wanting something like an extra towel or an extra blanket. As a learner in clinical practice, can you answer that call bell? Absolutely you can. So in this situation where you've got a patient that is wanting assistance, there are times in which you might want to continue that call bell, or you might want to go out and look for somebody else to support you, especially if the patient may need to be moved in bed or is wishing to get out of bed or go to the toilet. It might be mobility issues for them. It could be that they're attached to a machine of sorts. So you might want to just stick your head out and call for an extra pair of hands, or just say, is it okay if I help this patient out of bed? Especially if you've never met them before and you're new into that clinical area. If you're doing something alone, always make sure that A, you are able to do that as a learner in practice. There are certain things you can and can't do. And also B, is there something about that patient that you need to know beforehand? So do they have brittle bones? Or is that machine they're attached to important? Can I take the SATS monitor off? Can they take the blood pressure cuff off? And can I take them to the toilet? So it's always worth that time to just double check before you do something. Now within this situation, you are most likely going to be spending spending the most time with that patient. So they've called for you to help them with something. Especially if it's eating or drinking, you might be sitting there making a bit of conversation with that patient. For me, as a children's nurse, there are some aged children that you're not clearly going to have much of a conversation with, but you start to develop understandings of child development, milestones. And for the older children, young people and adults, of course, you can start to understand that patient's journey or just generally talk about their life. There's a real key bit here. When a patient is calling for assistance and they ask for an extra towel or some extra bedding, please do not say to them, "Give me 5 minutes." They will clock watch, you won't be 5 minutes, and they'll get angry. Take this from somebody that's learned the hard way. And I've not done it maliciously. I have had absolutely every intention to return to that patient within the 5 minutes, and I go down the corridor, go to the linen store, get the towel and go back. But when I go there, I see somebody else that may need help. When I'm in the linen cupboard, I catch the nurse that I've been wanting to catch all day and have that quick chat about the other patient or a discharge or an admission. And before I know it, I get called off to do something else. And it's only half an hour later when I walk back past that patient's room, they're still there waiting. It's a horrible feeling. They don't particularly like it either. And I've potentially had a really negative impact with that nurse-patient relationship. So never give a time frame. If you need to go off and do something to come back, just say you'll be back in a moment and you will help them then, or you will go and ask somebody else to come and help them. Never say, "I'll be back in 5." The second situation you're likely to come up against when you go to that patient calling for assistance is the patient or their family is requesting some information from you. So that could be, what time is the medical ward round? When am I being discharged? When is my next medication due? Or it could be to update you with some information in terms of a bowel movement or they've had a wee. Can you answer that call? Absolutely. Might you need to say you'll be back once you found that information out? Absolutely. Those situations are really important from a learning perspective because it helps you understand the general types of questions that patients may have about their care, about their day-to-day practices, and hopefully you can start to pick up some of the generalised answers to those questions. The time of day, morning, night that the medical teams are on the wards for ward round. You start to learn that day-to-day practice of the clinicians in that area, and if the question's about a medication, then it looks really good on you as a learner. If you came to me and I was a nurse in practice working with you, and you said, "What time is the next paracetamol due for bed 3, I'd be like, "You're on it. It's due in 10 minutes. Do you want to come and help me?" Are you waiting for some of these to get a little bit harder? Because they might just. But I suppose the first thing I really want to point out is yes, you're going to be nervous when that bell goes, but more often than not, it is those times of assistance or information. The next two that I'm going to come on to are lower down in terms of occurrence, but this is where we may start to encounter situations where you may need a little bit more support, and you certainly wouldn't want to be doing any of this on your own to start with. So the third type of situation might be that something is changing with the patient. That might be that they're in a little bit more pain. That could be they've noticed a rash, or they're starting to develop symptoms of sorts, or they're getting better and they're wanting to let you know. You can absolutely answer those calls and you can be the first person to go in there, but this is where your situational response needs to change a little bit. And this is where you might need to go into nurse mode a little bit quicker, and I'm talking about you assessing your patient. So the patient has called you, you've gone to the patient and you're in their cubicle or you're at their bedside. They say, "I'm starting to struggle to breathe a little bit." Instantly, alarm bells are in my head. Now, remember, while the patient has pressed their call bell, you can pull the emergency bell if you feel like A, you can see that patient is really struggling and you're worried, or you need somebody there to help you immediately and you don't want to leave that patient's room or bedside. Now, remember, the emergency buzzer isn't necessarily there once a patient goes into cardiac arrest. It's there to get immediate help. So if you're there on your own as a learner in practice, start using that emergency buzzer. I've said it before in other videos, you'll have the whole ward there within just a few seconds. And then what usually happens is we stand the call down, we turn the buzzer off, and we turn to everybody else in the room and say, "It's okay guys, I've got this." I'm there working with you then, and you turn to me and say the patient has said they're feeling like they're struggling to breathe. We do a systematic assessment. You go through your airway, breathe-in, circulation, and so on. You come up with your assessment values and you decide to make a plan. But can you answer that call bell? Absolutely. And are you going to learn so much stuff? Yeah. Are you going to get praised for being the person that went to the room and called for extra help using the emergency buzzer? Absolutely. Are you going to get ridiculed for pulling the buzzer when actually it wasn't an emergency situation and you didn't need the entire ward there? Definitely not. We know, we use it. We use that system where we need somebody else immediately in that room with us. The patient is alive, the patient is conscious, but we know it's time critical to make sure that that patient is stabilised. If you leave that patient's bedside on the hunt for a registered nurse or a doctor or somebody to help you, you are not going to find them. They're going to be busy with other patients. The easiest and quickest and safest route to get them to you is to pull that emergency buzzer. And the fourth scenario, last but certainly not least, and I said this kind of went in order of common occurrence, and I might have put this one first. I don't know. No, I think the occurrence level of this one is dependent on the clinical area that you're in. Yes. So this last one is when a machine is beeping. So a patient calls you to say, the pump is beeping. That could be a medications pump, a fluid drip pump. It could be a different piece of equipment in the room that's making a noise. It could be the vacuum system to a back dressing. It might be the airflow meter for an airflow mattress. It could be a SATS monitor, an ECG reading. The list is endless. And this is a really important situation where you must not do anything in the room. You can silence their buzzer, you can cancel the call, but don't silence whatever the machine is beeping. Remembering that you're a learner in practice, you do have the Teflon coating of being a learner. The person responsible for you in clinical practice is that registrant. However, it's always a good idea to try and make their life as easy as possible. So if you've silenced a monitor, or you've silenced a pump, or you've turned a piece of equipment off, do you really know? Have you done an actual assessment of what is beeping and why it's beeping? Probably not. If you have, brilliant, kudos to you. Leave the alarm going and say, I'm just going to find a registered nurse or whoever it is that you want to go and find, and I'll be back with them to sort this situation out. Again, if it's a monitor that's alarming and it's an ECG reading, a blood pressure, SATS, pulse, whatever it is on that system, and you're worried and you don't want to leave the patient, red triangle. Pull it. Sometimes they're blue. The emergency buzzer. So while you can absolutely answer the call, you're going to need to do a quick assessment of the situation to figure out exactly what it is that's A, alarming, and B, whether you can leave the patient's side to go and find somebody, or whether you're actually going to need to stay there and pull the emergency buzzer to get somebody to you. Sometimes by silencing a monitor or cancelling an alarm on a pump, it gets rid of the error message that's showing, and sometimes somebody will come in and say, oh, we just need to restart it again. But actually the error message might be showing high pressure reading in the vein that a cannula is sitting in, and that's actually not a very good thing to be doing, to just restart the pump without maybe either flushing the cannula or changing the position of that arm or limb wherever the cannula is positioned. So by getting rid of that error message, it makes the registered person's job a little bit more intricate in terms of what they need to do to find out what was happening, and they will stay there until obviously that situation is resolved. In these situations, you're going to learn a lot about technical assessment skills and sussing out what's going on, especially if it is a fluid pump that's reading high pressure volumes and you're thinking, well, it's going into their central venous access device, so that reading shouldn't be there. You shouldn't be seeing such high readings. Probably what's happened is the patient has coughed or moved or sat up, and the pressure is slightly shifted because, as we know, as you move around, your blood pressure will move around as well. And sometimes the pumps are quite sensitive, rightly so, that where they see high resistance, they're going to stop to limit any internal damage where constantly pushing fluid or whatever the medication is into that patient is quite a bad thing. So the pumps know, stop, and I'm going to shout for help as well. So you're going to learn an awful lot about sussing that stuff out and how you go about starting the machine back off. While you may not actually be allowed to touch the machines, if I'm there as a registrant and I know that I've done everything possible with the patient and I'm happy for you to restart the machine or to tell me what you think's going on, that's okay. That's because that's my decision. I'm with you and it's my registration on the line if anything goes wrong. I take full responsibility for the clinical care for that patient. So yes, you can absolutely answer those calls, and by being present when somebody comes to help you, you're going to learn so much. And it's about knowing what steps you need to take next. You can only learn what steps you can take next by being present in that situation. So don't shy away and go to those patients when they call for help. In all of these situations, you're going to develop so many skills, be that very quick, rapid assessment skills of your patients, developing your communication skills, being able to relay information to either the patient, their family, or the nurse that you're working with, or the clinical teams. You might start using SBARD more, your situation, background, assessment, recommendation, and decision, the escalation in communication around the clinical care of those patients. You're going to be able to develop things like empathy, being called to a patient's bedside when they need assistance. Don't take that lightly. Think about yourself in a hospital bed and you're calling for help. It may have taken you 10, 15, 20, 30 minutes, in my case, maybe even longer, to pluck up the courage to call for help because you don't want to be a nuisance. And when you attend their bedside, you are going to develop your bedside manner, empathy, communication, assessment skills. You name it, there's not a lot that you're not going to learn. You can also start to really get a feel of the teamwork that's behind the care of those patients in that area. And all of these things are things that you are being assessed against. Everything is within your assessment document, be that a clinical skill, competency, proficiency, or maybe a key objective that your assessor or supervisor has set for you in this clinical area. So start learning, start ticking those skills and proficiencies off, and start impressing those people that you're working with. Until next time, take care and be safe.